So, beginning of therapeutics. Has anybody been on Blackboard yet? Work? You guys can get in there. And okay, so this is the beginning of therapeutics, as you guys are all well aware. Left screen.
It's a 215.
And you probably heard last year this was a bit of a rough road for the therapeutics to start, but hopefully it won't be as rough for all of you. I'm Professor Teeter. I know many of you. I don't know nearly all of you. I know probably just a fraction. So I teach psychopharmacology, and this year I usually teach the entire module, but this year I'm going out of the country in a few weeks for work, not for fun. So you guys are going to be with Devin Sherwood the second half of therapeutics. So maybe good, maybe bad for you. I don't know. I haven't seen the teacher. So here's some logistics. This is important, so you got to pay attention here. Again, these logistics are in part to eliminate some of the things that we discovered last year, trying to eliminate any miscommunications. I'm going to have office hours for this class, and they're going to be on Tuesdays and Thursdays from 2:30 to 4. And what you need to do is email me and tell me that you want to meet with me, so I can expect that you're coming. I'm not going to sit in my office right at 2:30 to 4 and wonder if anybody's going to come or not. Shoot me an email. Tell me that you want an appointment. And office hours are going to be better for in-depth discussions. If you have a question, a content-based question, such as, how does a serotonin uptake inhibitor work? Again, is it serotonin or norepinephrine? A quicker content-based question. You should be doing that through discussion board, so I don't have to keep answering the same question over and over and over and over again, so that others can learn from your questions as well. So email me at cteeter@une.edu. Now, the important thing is, because I have a lot of, I try to be savvy with technology. I wouldn't say that I am, but I have a lot of filters set up so that things automatically end up where they're supposed to be. When you email me, you have to put in the subject therapeutics, and then like a one-word like therapeutics. I'm struggling, something, so it'll actually end up where it's supposed to be first of all, and then I kind of have a clue, oh, this looks important, I better get on this right away type of thing. So if you email me and it doesn't have therapeutics in the subject line, I may never get it. I may, but I may not. So again, that's because last year, with emailing, there's 100 of you, one of me, and there's emails going back and forth. And did you get this? No, I didn't. Was it Blackboard? Was it email? Was it this email address? That, trying to eliminate a lot of that noise to focus on content. Make sure that you follow these logistics. Questions, if they're content-based, you should be either doing office hours, discussion, or in class at the end. See what happens every time is there's 5 to 10 minutes left of class. I say, does anyone have any questions? Everybody says no, we're fine. And then 10 of you follow me out of the classroom and 10 questions, 3 of which are the same. And other people can learn from that, and it's efficient. It's all about efficiency at this point. Got a lot of things going on, and everybody needs to be efficient. So, and then case conferences. Have you guys heard about case conferences much yet? So I also posted the syllabus today. There were changes. There was even another last-minute change that one of the people that are going to be teaching in this course just sent me, so it's going to change again, very minor change. But if you look at that, you need to look at the syllabus and become familiar with the syllabus like you do with any class. But case conferences are going to be Tuesdays and Thursdays, and it's basically the registrar takes half the class alphabetically and splits them. Half of you go on Thursday, half of you go on Friday. And case conferences are going to be things like literature discussions. Has anyone in here ever done a journal club yet? Only 2 of you in this entire room have ever done a journal club? 3? Yeah, 3. Okay, so that's when you're a PharmD working in a clinical environment, you should know how to walk through a scientific journal, right? And beyond just, oh, it's industry funded, it's bad. You should be able to walk through an industry, or any trial and assess the good, the bad, and the ugly. So part of case conferences are going to be those. Part of case conferences are going to be things like SOAP notes. Who's written a SOAP note? Like 5 of you? Okay. All right. So yeah, you guys are in for some changes. So case conferences are going to be what those are all about. Now last year when I taught this, there were 5 snow days in my section, and we ended up hijacking a lot of the case conferences for lectures because we were falling behind. 5 snow days. I think I taught once the first week, and that was a 4-day work week. So unless the winter dramatically changes quickly, the way it's supposed to go, or Thursdays and Fridays are for those things. Tomorrow we're going to start out with a journal. We're going to start with an article. I think I'm going to send you an article today on, well, I'm definitely going to send you an article, but I think it's going to be on a new antidepressant that a couple students asked me about that just came out. I've never even actually seen a tablet or a capsule or anything. I mean, it's brand new. They're approved, and then eventually they trickle their way to the shelves. Well, 2 of the P3s actually saw this sitting on a shelf, so it's out there. Has anybody ever heard of Vibrade? Right. Serotonergic medication, which we'll get into down the road, but you're going to likely be receiving an article about that medication just to get rolling. And the reason I chose that one is just because it's so new. Got to start somewhere. I haven't even, like I said, I've never, ever used it in any way, shape, or form. So it's going to be, I'm going to be reading it as well. But we're going to walk through a journal, how you break it down, how you assess it, so on and so forth. Okay? And again, the registrar, does anyone know based on Blackboard, or the registrar already locked you guys into 2 groups? You already know that? Okay, good. Last year it didn't show up, and then we had to manually do it, and then everyone's begging me to switch them, and I don't have that authority, and so that's good. You already switched. Good. Computer maintenance, that's the classic. Exam time comes around, and the computer doesn't work, it doesn't have Respondus, it doesn't have Blackboard, it doesn't have Google, it doesn't have anything. What do I do? Hopefully that won't happen here, and hopefully you'll have that all resolved for the first quiz. That being said, when you look at the syllabus, you're going to see that part of the way to assess you guys at these conferences is by giving quizzes, right? That's part of the, like for example, God bless you, for journal clubs, right? I would write up a quiz that's basically content-based, that after you work together in groups, at the end of the case discussion, it would look something like this. You take the first little while to get together with a group, walk through the article, discuss the article, break it down, strengths, weaknesses, methodology, results, outcomes, things like this. Then we talk about it as a class and bounce ideas around, and then you take a short assessment on things like what was the primary outcome measure. Okay. Is anybody familiar with what the primary outcome measure means? Anyone know what that means when I talk like that? Just curious how far we have to go. Anyone? Justin?
So the article in question, I guess the research question was about those what did they measure?
What did they measure? Yeah, primary outcome measure, I have a study on an antidepressant. Did I measure the right thing? Did I measure the right construct in order to see if the antidepressant induced depression? Okay? So then you'll take an assessment on that. To basically say, yes, this person was here, and yes, they, at least from working in groups and reading the article, had some idea of what the article was about, how to break it down, or they did. Very rudimentary type assessments. Psychopharmacology, the study of the effect of drugs on the mind and the behavior. I just thought I'd fill in a definition. I also had a pronunciation in there, but I don't think we need that. It just looked cool. So today's a very, very brief overview of things that are going to come up again and again throughout the course. And last year, I did some of this lecture. I've edited. Each year, the lectures always get edited to some degree. Last year, students said, "Oh, this is we already had this, and then the first quiz or first exam came around, and they didn't have it. So I'm not going to make any assumptions on how redundant this information is or how redundant it isn't, because again, some of last year raised their hand. Oh, we already had all this stuff. But I can tell you by her assessment, everyone else's assessment, it wasn't that clean cut. So I'm going to assume you need to see this stuff. Information. And I'm going to kind of talk about the DSM-4, talk about the brain, but we'll get into it. I'm not going to ramble on about it. Okay, so the human brain, my favorite organ. So you look at the human brain, and the way that I've kind of organized this is there's neuroanatomy, right? Where neuroanatomy is you take a large piece of the brain and you kind of categorize that part of the brain as having a certain function. Right? So if you look at this brain, the blue area, for example, the frontal lobe. The frontal lobe is what separates us from monkeys and other primates, right? The frontal lobe is what makes us higher functioning individuals. And I use that term loosely. And then, as you go down towards the spinal cord, right, as you get closer to the spinal cord, you get more primal type behaviors, sex, breathing, cardiovascular function, right? All that stuff's in the middle of the brain to keep you alive and to help you procreate. But to sit here in therapeutics and write your first soap note, you're going to start using the frontal lobe to be able to organize information and prioritize and so on and so forth. So you need to do well in this section, you have to have some idea of what the different sections of the brain are responsible for. We're going to talk a lot about the frontal lobe. We're going to talk a lot about, in a slide or two, I'm going to go a little deeper into deeper layers. We're going to talk a lot about, mesolimbic dopamine pathway, nigrostriatal pathway, et cetera, et cetera. So you definitely need to at least have, broad conceptualizations of what these things do. Now, you guys have had this in, how long has it been since you guys have had the anatomy of the brain? Years, days, years. All right. Well, it's easy to forget, so you're probably going to want to refresh yourself, because I can guarantee, you're not going to do well. Because psychopharmacology, the reason I put that definition, let me go back, I was talking about the study of the effect of drugs on the mind and the behavior. Is psychopharmacology to me has always meant, well, I know the mechanism of the drug, right, which is basic pharmacology, right? Basic pharmacology, I know the mechanism of the drug. Well, in psychopharmacology, you absolutely have to know what the area of the brain is doing, and then you have to match them, right? Because different areas, there's so many different areas of the brain that do so many different things. You have to match the medication, its mechanism of action, to what that area of the brain does, right? It's not one size fits all. I mean, your heart is amazing, but there's some very general aspects of the heart that you can apply. If you use a beta blocker, there's beta receptors all over the heart. Well, here in the brain, a beta blocker in one area of the brain may not have the effect that it does in another area of the brain. not that, we do use beta blockers in psychiatry, but it's not a first-line treatment, but just to make the leap, right? So you have to be able to match the two. So what I'm telling you is know the brain. And in seeing that, taking a look at that, you guys, I don't necessarily want to walk through every list of every item, but you see things in the brain that you're looking at that diagram and saying, that doesn't look familiar, or I don't know, I don't recognize that, I don't know what he's talking about. Right? Primal brain, and as you get out to the outside, more higher level functioning. Do you want me to walk through it more specifically? Do you see things in there you don't recognize, or is this, you feel pretty good with this? It's going to get a little more complicated soon. Yes? No? So, all right, I'm going to go through the lobes. The cortex first. Parietal lobe. You see the parietal lobe right there? Here's my pointer here. Can you guys see that? Maybe if I draw on it. There you go. So like for example, parietal lobe and the frontal lobe and the occipital lobe and the temporal lobe, right? So those are large areas of cerebral cortex that are all involved in higher level functioning. So that's a way to kind of break the cerebral cortex into a couple different areas, and then within those areas, so frontal lobe, you're talking about intellect and speech, things like this. Temporal lobe, that's a very easy one because it's near your ears, right? So a lot of them are going to make sense. The ears are within along outside of the temporal lobe, so the information doesn't have to travel too far. You take something like the occipital lobe over here, however, and it's in the back of your head, so the information actually has to travel all the way from your eyes, all the way through your brain. And I used to go a lot more into this with cranial nerves last year, but it's not the most exciting thing to teach about cranial nerves. So I tried to replace that with some other stuff, although cranial nerves are highly important. They control the nervous system function in your head. But so it's not always, this is geographically on the head or anatomically on the head where it is to relate to, your orbital cortex, for example, isn't your primary visual processing center, even though that's where you think it would be based on location. The optic nerve actually goes all the way through the back of the head to the occipital lobe. Anybody want to guess why that might be? Why would give me a theory on why your occipital lobe for your vision would be in the back of your head and not right behind your eyes? It does have to travel, and it is in reverse, and it goes to the optic chasm, and your images reverse and all of that. But you could do that pretty quick, like in a short amount of space. Why did he travel all the way across the brain? This is just a theory. I'm sorry? Well, that's an interesting guess, but a lot of the stuff, the higher executive functions in the frontal lobe.
So that activates a number of different portions of the brain.
Another very good answer, that it activates other portions of the brain, right? Visual is so important to us.
And you have a primary and secondary source, like major past memories for the vision that create part of it.
Well, that goes along with having different pieces of the brain involved if you have to travel to the back of the brain. I think it's something more pragmatic. Protective, right? The eyes, and I used to go a lot more into this, but again, it's kind of hard to teach, and you guys are not in ophthalmology, and so I kind of backed off a little bit. But it's protective. For example, the eyes are not only broken into two eyes that transfer information to opposite sides of the brain in the back, they also have regions of the eyes on both sides that take information and take it to you. So if I have information coming in from this side to both of my eyes, pieces of that story go to both sides of my brain. So there's all these built-in layers of protection for your eyesight because it's so important, right? it's kind of like putting all your eggs in one basket. If you put all of your visual processing systems all together in the front of your head, and something happens, not only did you injure an eye, you could have also injured the brain matter that controls the eye, right? But you separate it out, you separate the two out some distance, and you have different fields of both eyes that transfer information, some to the same side of the brain and some to the opposite side of the brain, depending on where the information comes into the eye. And I'm not going, like I said, not going to get too much into that because we're not in ophthalmology school. But the point of the matter is, it's protected. Likely, that's probably the most reasonable answer. So, so the back of the head controls a lot of your vision, and that was just a tangent, circumstantial tangent, but very important information. But as pharmacy students, I don't want to get too far off into those kind of tangents. Parietal lobe, your primary somatic sensory and motor information is in the parietal lobe here, kind of. And then, again, we're going to go on the next couple slides a little bit deeper into some deeper layers like the hypothalamus, the thalamus, the pituitary gland, the amygdala, the limbic system. That's where in psychiatry it's going to get a little bit more interesting. All right? But this is definitely something you need to study up on yourself and all the little minute details instead of just having me sit here and list item after item. I want to spend a little bit more time where we can have a direct impact with psychopharm. So this is going a little bit deeper into the brain. And now what you have, is that, you can stay there. I can discard all this. Does anyone know if I can discard all this? All right. Not save it. Yeah, just don't save it, right? Because I don't want all this. So now we're going a little bit deeper into the brain. And what you have is, you still have the prefrontal cortex, which is what we just talked about, the frontal lobe. So you still have the prefrontal cortex being something that we can manipulate with pharmacology. Okay? And then you're going to see again and again and again and again ad nausea, but I can guarantee, even though you see it over and over and over again, it's still going to take you a while to understand, or at least it's going to take some of you a while to understand. So I don't feel too bad about repeating it over and over. You're going to see a few systems that start right here in this brain neurotransmitter center. And you'll notice you're going to get the full explanations of these in plenty, but these are 4 examples of neurotransmitter systems: the ventral tegmental area, the substantia nigra, the locus coeruleus, and the raphe nuclei. Those are origins for the neurotransmitters that we're going to discuss at length: dopamine, norepinephrine, serotonin. All right? And again and again and again, you're going to see this system. For example, dopamine starting in the substantia nigra and then going to the frontal part of the brain. Serotonin starting from the raphe nuclei, going towards the front of the brain. Norepinephrine starting from the locus coeruleus, going towards the front of the brain. And you're going to, like I said, you have to understand these concepts. It's an absolute must to understand, because that's what we're going to manipulate primarily with medications in this course. Is you're going to, every antidepressant known to man manipulates either serotonin, norepinephrine, or dopamine. So you have to know what you're manipulating. Well, what you're manipulating are these systems that would start, all of the neurotransmitter systems start down here in this primal area of the brain, and they project forward to these other areas of the brain. For example, one of my favorites, the nucleus accumbens. That's your reward, pleasure, motivation center. It's there for procreation, but people hijack it for substance use. I don't talk plenty about that. And then also, we're going to be able to have some effect in some of these other systems, like the amygdala, which is your emotional memory. Hippocampus is your memory. Well, and when I say, I never like to speak in absolutes. When I say your memory, it's not only memory center, but it's a very key player in your formation of memories. The amygdala is emotional memory. The striatum is a relay center for thinking about behaviors and then making them happen. So there's a lot of motor system involved. And again, you don't have to get every single word on. We're gonna break this up in pieces as we go. This is just to say, at the end of today, all right, if I want to, move forward in this class, I'm going to have to know what the striatum is. I'm going to have to know what the nucleus accumbens is. And then you're going to have to do some studying on your own. And then in class, in each disorder, we'll tease them apart a little bit more. So I'm going through this quickly because it's just meant to say, okay, be prepared, be warned, so to speak. So to move ahead here, now this slide, I'm just giving you some of the areas of the brain. This slide starts talking about some of the behaviors that you can actually measure in people that are likely, at least in part, controlled by those brain systems. For example, I was talking about the striatum here being one of these relay systems for behaviors and action. So it coordinates what you're going to do and helps you do it. And it's kind of an oversimplification, But if I'm going to initiate a behavior, pick up my Gatorade, the striatum is partly involved in that. The caudate nucleus is going to help me process the information to actually, to make the movement, and then the putamen part of the striatum is going to help me actually make the movement. But like I said, we're going to get into all of this more and more and more. Point being, you have to be familiar with the striatum because one of the medications, for example, antipsychotics, they have very deleterious effects in the striatum, which accounts for one of their biggest side effects. So, movement disorder, if you put two and two together, antipsychotics cause movement disorders. Part of that is, at least part of that is attributed to the fact that they block dopamine in the striatum. But again, you get to all this class by class. So, you need to know the brain, right? Now, to take it one step further, I'm going to give you an example. I'm just simply giving you an example of 3 neurotransmitter systems. So first you have neuroanatomy. That's like these big, the cortex, the thalamus, these big chunks of brain matter that function. And then we took it down to a little bit deeper layers on these last 2 slides, kind of talking about, okay, you have these areas of the brain that you can correlate to behaviors. Now we're going one step farther than that and saying, here are those neurotransmitter systems that I mentioned. You can actually follow, for example, this is a dopamine slide, and if you look at this, this is where it starts. This is called the mesolimbic dopamine pathway, which we'll talk about in both substance use and schizophrenia. The mesolimbic dopamine pathway goes from the primal area of the brain out to the nucleus accumbens. So that pathway would be the mesolimbic dopamine pathway. And it is the pathway that's the least common denominator for every drug of abuse known to man. Every drug of abuse known to man, at least in some way, shape, or form, increases dopaminergic transmission from the ventral tegmental area in the middle part of the in the primal part of the brain out to the nucleus accumbens. There's a lot of other stuff too, but that's the least common denominator. So we're going to talk about that at length. Norepinephrine. I'll give you an example. The norepinephrine, where is that? The norepinephrine pathway that starts in the locus coeruleus in the primal part of the brain, and that goes all the way out to the prefrontal cortex. Let me put it back on you guys for a second, so I have to talk the whole time. Allie. Yeah, the disadvantage of knowing me before this class is that I know it has a handful of people to call out. What would be, from what you remember about norepinephrine, what would be an advantage of increasing norepinephrine in the prefrontal cortex? And if one of her friends wants to help her out and throw her a lifeline, that's fine. What? No, look it up online.
Oh, I'm not. I was taking notes.
Anybody want to help her?
Does it have a stimulatory effect?
Stimulatory in what way?
Like increasing concentration or functioning?
Kayla works with me on a research project, so she better know some of that stuff. Yes, if you increase norepinephrine in the prefrontal cortex, that can help with things like alertness, cognition, attention. I think it's even, if you go back a couple slides, attention, concentration, helps you with impulse control. So think of a medication in a disorder where this applies. ADHD, right? ADHD, you increase norepinephrine in the prefrontal cortex, and it helps you with impulse control and higher executive function. So that's how I want you to start connecting the dots here. Here's the pathway, here's the neurotransmitter. I know the mechanism of action of the drug. How am I going to match them in some way, shape, or form? And then we're going to talk about adverse effects and drug interactions and all the other things that help you choose. But for right now, I want you just to focus on these systems. Serotonin. What example did I pick here? To the amygdala. So serotonin, starting here in the primal part of the brain, going down and projecting to the amygdala. Now, serotonin has a lot of receptors, a lot of subtypes. There's pre, there's post-synaptic, which we'll get into. But it has a modulatory, a neuromodulatory effect. So it can help regulate other systems of the brain. So what might increasing serotonin in the amygdala, based on what I said a couple slides ago about what the amygdala does, what effect could you have? The mood, but not in the amygdala.
Would it decrease anxiety?
It would potentially, one of the theories, because we can only talk in theories in psychopharmacology. Well, there's some exceptions now. Science is finally imaging. We can finally start talking about some facts. But one of the primary theories of serotonin and anxiety is that if you're modulating an area like the amygdala, and you're modulating it, and you're kind of dampening it, that you can actually reduce fear and anxiety. Which is the case. If you give, in every rat model known to man, if you give the serotonin medication to a rodent long term, it's going to decrease their fear avoidant behavior. One of the theories is that maybe you're helping it modulate at the level of a brain structure like the amygdala. Okay? So there were 3 examples. Then to go one step further from the neurotransmitter system, you have the synapse. What's happening at the synapse? So I gave you an example of 3 synapses. Oh, and again, this is important. We have a subscription, I believe it's still active. I looked the other day and I could access most of the stuff. Stephen Stahl's Essential Psychopharmacology textbook. I had them ordered last year, and it gives these pictures. Now I actually own my own personal subscription, so I can do a lot of fancy things with the pictures. I doubt that UNE has the access where you can actually, maybe you can manipulate the pictures. I don't know. What I'm saying is, if you wanted to go in and get some of these pictures and pull them off, I don't know if that's possible. But the textbook is available at UNE. I pulled it up yesterday without signing in, and it gives you a lot of these cartoon type. He's famous for making psychopharmacology more user friendly because of all the cartoons. It's great. He puts everything. The thing is, though, remember, it's theoretical psychopharmacology. He doesn't reference anything. He makes wild, assertions about what works and what doesn't. But in terms of helping you conceptualize what might be going on, Stephen Stahl's Essential Psychopharmacology is a good. It's recommended reading. The Puro textbook, which you'll see in your syllabus, required reading. Stephen Stahl, highly recommended. I don't think any test questions from Stephen Stahl because he's so theoretical, but I would definitely give you a lot of pictures that help you grasp what I'm talking about. Hopefully. Okay. So, 3 examples. This is kind of more basic pharmacology. Well, this is what's happening at the neurochemical level. And basic pharmacology would be, I gave a medication to interact with that synapse. That's basic pharmacology, but what you have to know is, well, in what system and what part of the brain, because it's going to be a completely different outcome to block serotonin or norepinephrine or dopamine in one area of the brain as it is in a different area of the brain. Completely different. When you get to schizophrenia, that's one of the best examples where if I block dopamine in this pathway, it's a completely, entirely different outcome than if I block dopamine in this pathway. All right? But we get to that in schizophrenia. But you have to know these layers to make it happen. Cranial nerves, like I said, I used to talk a lot more about these, but they're hard to teach because you can't. They're cranial nerves. They are what they are. There's 12 of them, and you have to know what they do. The reason I picked a couple of them out that you really must know in the neuropsychiatric interview, which I'm going to go into here soon. As again and again and again, as you see more medical documentation, you're going to see things like PERLA and EOMI, and that has to do with pupils equal and round and reactive to light and auscultation, extraocular movements intact. My point being, you have to know the cranial nerves. I feel they're important enough to mention. I'm not going to go into them again at length. Who has at some point been accountable for the cranial nerves? Better be at least half of you. Who has not been accountable for the cranial nerves at some point? Only a few of you? So you guys are all, if I gave you a quiz on cranial nerves right now, you'd all do pretty well? Or if I gave you a data refresh, you'd all do well? Yeah? Anybody feel like they wouldn't do that well if I refreshed this tomorrow? So if you don't feel that you would do that well in a quiz tomorrow, you might want to go back and look at them. Again, for your own education, I'm not going to give you a quiz on cranial nerves. Point is, they're important, and when I get to the neuropsych interview, which is the second part of this presentation, they're very important. Okay, so that's a quick overview on what's kind of going to be expected from you, and that's the fun part for me is how drugs work, parts of the brain. And now I'm going to talk about the other part. For every lecture that I did, or that Devin, I'm assuming every lecture that Devin Sherwood gives as well, you're going to have to know DSM-4 criteria. Not yet. Yeah, it's coming out, but not yet. We're still on DSM-4. So anybody have any questions on all that stuff I just threw at you? No questions? Again, I'm not expecting you to master the material at that point. It's just, here's what's coming on those situations. All right, so now let's talk a little bit about the interview. Now, therapeutics in general, there's a huge push in general that in therapeutics you should not only know how to go through a patient case, but also that you should be able to write a SOAP note, for example. That's a standardized way to write medical charting. So I'm going into the interview part here early on because the DSM-4 that I'm using is the gold standard diagnostic Bible for psychiatry. It's going to feed the part of the interview that's going to go into your assessment, your SOAP note, and your patient presentation. Okay. So the DSM-4 is the gold standard diagnostic tool, as I just said, and you're going to become very familiar with it because at the beginning of every lecture I talk about here are the symptoms that have to be for depression, for example. Anhedonia. Anhedonia is the lack of interest in things that someone used to enjoy. And are you kidding me? Are you kidding me? Look at this guy. Oh my God. No, he's all right. He can't run very fast, but he's all right. DSM-4? Jason. Jason. Give him a 2-minute spiel on DSM-4.
For anything psychology related, it basically will take you step by step to diagnose. It's a really creepy way to self-diagnose. Encourage people if you think you have a problem to bust it open. It will tell you what's going on inside your head.
Thank you.
It's extremely dry.
You're not extremely dry. You're hilarious, man. He's diagnosing himself with DSM-4. So yet another use of the DSM-4, you can diagnose your pathology. It's it's like a choose your own adventure type of book where I always feel kind of guilty saying that. Yeah, but it is. You walk through this process where has the person experienced anhedonia? No. Has the person been irritable? Yes. Has the and you go through all these symptoms, and at the end of the day, you have to have a required number of symptoms that have to occur over a time frame in order for it to be plausible that you would have that diagnosis. And again, we're going to get very specific as the lecture modules go on, but you're going to see it again and again and again. So you have to know DSM-4 because if you don't know what you're treating in psychiatry, you know, it's like psychiatry is already at a disadvantage that we don't have, you know, a blood test for schizophrenia, a blood test for depression. You know, you can take a blood pressure and you can target that, and that's an advantage of cardiovascular medicine, right? You can actually look at a number and treat the number. You know, the flip side is I can pull up JNC, and I'm not even an expert, but I could treat somebody with blood pressure. There's pluses and minuses to both sides, right? I would love to have something that I could target, something like a JNC, where I could just walk through and be like, JNC 7, that's the cardiovascular guideline, where it tells you what to do. So you have to know what you're treating the best that you can in order to feel like you're actually making some progress towards a disorder. So if I think somebody has depression, but they actually have bipolar disorder, and I give them an antidepressant and I induce mania, that's not good, right? So you have to know what you're targeting, period. So you know the DSM-4, that's going to be one of the first steps. Now, the next few slides, you know, are very boring because it's just basically the different components of an interview that if you pull open any chart on writing a medical note or a patient case presentation, it's all standardized the same way. Everybody walks through the same steps. Now, your institution, you may leave this step out, or you as an individual clinician, you may feel more importantly about this, or you're on this unit treating this kind of patient, so this is more important. But in general, patient case presentations and SOAP notes are very standardized. All right, you start talking about the patient. This is a 36-year-old white male with, right? That's every patient case presentation you ever go to is going to start like that, because you have to have a standardized language in medicine. Now you get right to the chief complaint. What is the chief complaint? Why the patient comes in and says, I went on a spending spree, I bought a new car, I didn't ask my husband, and you know, I spent way more money than we have. I put this, you know, and that morning when I woke up, I wasn't planning on buying a car. I did something really impulsive. So the patient tells you they have a history with bipolar, for example. I think I'm having a manic episode. That's in the patient's own words how they ended up in this situation. Then, and I'm not going to go through every point by point, because you can look at. I'm going to highlight some of the more important ones. History of present illness is where you start getting that. This is the story that led up to that woman buying the car. She didn't just wake up one day and buy a car. What other information's in there? Did she have a fight with a family member the week before? Is it the winter and it's dark at 3 o'clock? I mean, there's all these other things that creep up that inform the history of present illness. Then you have the past psychiatric history. And depending on where you're at, if I was in cardiovascular, for example, this could be past medical history, right? So a lot of these components, there are subtle changes, but in general, you're going to see standardized language. So for those of you in a hospital in 5 years, or in your APPEs in a couple of years, mark my words, you'll see some format, some variation. Who's ever seen a medical record? One person? Two? Okay, a handful of people have seen a medical record. Did you see this kind of language? Do you recall? Right? So this is, and I just happen to be going first. You know, anybody in any discipline could give you this part of the lecture. It is what it is. I just happen to be the first one out of the gate, so you're getting it in this class. But you could be an infectious disease person giving the same kind of note. With exceptions, like DSM-4 criteria, past medical history, social history. So there are certain components, depending on your discipline, that become more important. So for somebody in psychopharm, social history becomes extremely important. And I'll give you an example of a case where this is. When I was doing a residency, I was doing these intensive psychopharm consults where these patients were treated for 30, 40 years, and I'd have to go through and go through all their medical records and try to figure out, are there any options left or any options that should be revisited in this person, right? So I'd go through, and I remember, everyone has those pivotal moments when they, wow, I didn't see that coming, and you learned something completely unexpected. Everybody has them, it just depends when and where. Well, I did this consult, and I was really proud of myself. Found out the person was basically going back into the same situation that they were in before, with lack of support, lack of money, maybe lack of housing, all these things. And my mentor at the time was like, well, you recommended olanzapine, because I practiced the most expensive medication, probably the top 10 most expensive medications in America at this point in time. You think they're actually going to take that medication? And I didn't even see that coming. I was just thinking, what's the best medication? Because I got, get into, here's the mechanism, here's the areas of the brain, here's the disorder, and I didn't find any contraindications, and the one time she took it, she wasn't on a sufficient dose, and et cetera, et cetera. But I didn't even consider the social history. There's no way this person's buying olanzapine from Zyprexa. Even if you're working full-time with the support system, Zyprexa looks bad. I'm going back a few years when it was one of the first, the second antipsychotic, and very expensive. Literally carrying Lilly, that's how expensive and how much it was prescribed. So you have to think about different aspects of the interview depending on the discipline that you're in, right? Mental status. I'm actually going to mention a couple of scales that you can use, but I chose two very, very common scales. Just to highlight the fact that not only do you have the interview, but you have the scales. So the DSM-4 is actually a very intensive diagnostic procedure, but then you can also augment that with scales to give additional information. Multi-axial diagnosis, we're going to talk about that in a second. So we're going to talk about it right now. The multi-axial diagnosis is another way to try to standardize what you're dealing with. So you have in the world of psychopharm, you have your Axis 1 diagnosis, and that's your psychiatric disorder. That's why you're being pulled into the treatment situation, because they want to know what to do. Then you have Axis 2, which is, there's a lot of comorbidity of Axis 1 psychiatric disorders with personality disorder. Now the big difference here is you can't treat somebody's personality with a medication, right? As much as you want to, you can't treat somebody's personality. Those are long behaviors and habits that they've been pulling along with them for years and years and years. You don't just correct serotonin and that goes away. So you have to know what is the person's Axis 2, because there's nothing you're going to do pharmacologically to address that. Relevant physical disorders, say, I give you an example on the case, we'll probably walk through it a little bit at the end, but say somebody has severe cardiovascular disease. Can somebody, based on what you guys know at this point in your pharmacy career, you may or may not know this, can cardiovascular illness lead to depression? Yes. So if you were trying to treat somebody, isn't that a piece of information you would want to know, that they have a cardiovascular illness, right? So that's why, even though you're working, now it doesn't mean you're going to do anything about it. Psychiatrists are famous for referring out for all the medical complications, just like everybody else is famous for referring to psychiatry. It's one of those, stand alone, oh, that's psych, and then when they're done with psych, okay, they go back to the medical and get their diabetes taken care of. It's, that's lessening, but it's still the case. But you want to know what's going to impact your choice. If I have, going back to that Zyprexa answer, if I would have given Zyprexa to somebody with diabetes, because I didn't know that they had an Axis 3 diagnosis, that would have been malpractice. So you have to know these other pieces of information. And then relevant Axis 4 is environmental or psychosocial stresses. We talked about that. If you don't have a social support system and you don't have money and you don't have housing, those all play into what's going to happen once you're untreated. And then Axis 5 is the gap, which I'm going to show you in a minute.
Can you go through some of the acronyms, just so I know what maybe the gap and the SOAP and I just missed a couple.
Yep. So the SOAP note, did I mention the SOAP note already?
You mentioned it, but I don't know what it means.
So the SOAP note is a way for you, it's basically the information I'm giving you now in the format subjective, objective, assessment, and plan.
Okay.
So when you write a SOAP note, it's basically, I'm giving you the interview side of it right now. I'm giving you, you're going to sit down and you're going to walk through all of these steps. And you're going to want to hit all of these areas. And you're going to want to cover the mental status exam. And you're going to want, as a clinician, you're going to want to cover the diagnostics. Well, eventually you have to document all this. That's where the SOAP note comes in. You actually write a medical note in the chart that would be considered a SOAP note. And by the time you're done with therapeutics, you're going to be an expert on SOAP note.
And I just want the HPI, besides that, HPI?
That is the history of present illness. That is the history of present illness.
And I'm sorry, just one more.
MSE/PE. So that's mental status exam/physical exam. What else? See, I'm so used to using them, I take them for granted. And you take them for granted that HPI is just common nomenclature, and eventually you'll be throwing that around like HPI and
So,
yeah. We're going to talk about that one. We're going to talk about that whole scale in a minute. What's that?
I need a PPH, PMH, SH.
All right, let me go through them real quick. Okay. So, the DSM-4, I have that up in the title, the Diagnostic and Statistical Manual of Mental Disorders. I have the CC is the chief complaint. HPI is the history of present illness. The PPH is past psychiatric history. The PMH is the past medical history. SH is the social history. FH, well, I actually wrote out family history. MSE/PE is mental status exam/physical exam. And I threw an article up on the Blackboard for background reading, and that kind of talks about walking through an interview. So some of these terms you'll see in there as well. Not necessarily every term, but there are some overlap. Because not everyone's going to do this identically, but like I said, if you go into a hospital and you'll know, okay, this is how this hospital does this, and here's the information, and it's going to look something analogous to what I'm presenting today. You go to a different hospital, it might look a little different, but you're going to have a lot of the same components. If you read that article that I put on Blackboard for background reading, again, seeing the same components. So GAF is the general assessment of function. And that is, the GAF is actually an instrument that you use, and just as the title says, it's a general assessment. It's very broad, and I put some items in here for you. That right there. We'll look at that in a second. So there are different kinds of scales that we're going to talk about in the psychopharm module. Very general scales that I'm going to give you two examples today. I'm going to give you the general assessment of functioning, and I'm going to give you the mini mental state status exam, or mini mental state exam. And so those are just, you can use those in any setting. You could assess mental status anywhere, anytime. Then there are going to be more specific scales, like for example, tomorrow and Friday when you do the journal club, there will be a primary outcome measure, and I guarantee that it's either going to be the Weimers or the not the Weimers, the HAM-D or the MADRS. The HAM-D and the MADRS are two gold standard depression rating scales that if you want a medication accepted, if you can show a decrease in a few points on one of those, you're going to get your drug approved. We're going to talk about that. Point being, there are scales that are very specific to a condition, and then there are going to be very broad scales, very general scales. For example, the GAF is from 1 to 100. Are you very impaired or are you very healthy? And generally where you'll see this is on admission and on discharge. This is not a scale that's going to be sensitive to change over time. It's not going to be, oh, we showed a 3-point reduction on the GAF and our drug is great. That's not the kind of scale it is. It's a scale that just gives you a general, did they trend to get better or not while you treated them? So if you look at like 91 to 100, superior functioning in a wide range of activities, life's problems never seem to get out of hand, is sought out by others because of that person's many positive qualities, no symptoms. virtually nobody in the United States, and I'm not joking, is going to get 100. Nobody is ever going to get 100. Can you name one person who would get 100 that is absolutely unflappable, unaffected by any stressors, no problems whatsoever, no impairments, no disruptions, no disagreements? It's nearly impossible to be. That's the perfectly adapted individual. I've never met anybody perfectly adapted. Anybody. So, what's that? Owen McQuaid, right? You remember that one? That's probably before your time, right? You gotta watch Owen McQuaid. So, generally what you'll see is somebody will be hospitalized with something like 50 very serious symptoms, suicidality. You know, there is a reason to hospitalize them. Usually that involves danger to others, they can't function, suicidality, which I mentioned already. So you'll generally see like a 50 or below, and it gets worse from there. If somebody actually tries a suicidal attempt, that's when you start talking about a 1. If you actually attempt suicide, that's how you earn the lowest possible score on a scale. It basically means if you're willing to take your life, that's about as bad as it is, right? That's a 1. The perfectly adapted individual that I've never met is 100. And then there are categories within that scale that you choose from. It's a very, very general scale. Not to be used, like I said, it's not very sensitive to change and things like that. It's a, did they trend to get better or did they trend to get worse? Now, has anybody seen MMSE, the mini mental state exam? A couple people? 2 people? So this is one of those scales. You can give it in Alzheimer's, you can give it in depression, you can give it in substance use disorders, you can give it in schizophrenia. It is a very quick, or relatively quick, instrument that you, what's that? Yeah, I mean, quick and dirty, but it has a lot of validity. Has validity, reliability. It's one of the gold standard scales for assessing somebody's mental status at this point in time. To give you some examples, everybody who's ever been admitted to an ER, where are you, what's your name, who's the president, those kinds of things. Are you oriented to person, place, and time? Registration. So I'm going to say to you, okay, I want you to name these 3 objects. And I say Gatorade, computer, and clock. And can you say that back to me? Are you registering what I'm saying? Are you registering the information? Right? And then you get a point for each one that you get correct. Then attention and calculation is either generally going to be something like spell world backwards or serial 7. Can you count from 100 5 seconds down? Things like that to see if they actually can, do some of these higher order processes. And then recall, and you come back and say, what were the 3 items before? And I've done this. You're at a party and you're like, let's do the MMSE, and rarely does anybody ever get the recall. Try it. Name 3 items, then come back a little while. And virtually nobody ever gets it, but because they're distracted. But you'd hope that if you're in a medical situation and somebody, you're being very serious, and that person's probably scared because they're sick or whatever. It's not going to be as abysmal of a failure as doing at a party. So language, there's a whole bunch of points for language, which is, name a pencil, name a watch. You would actually point at it, can you name this? So you can go item by item. I'm not going to go through all 30 points. Point being, this would be a scale that would become part of the interview. It doesn't replace the interview, it would be part of the interview. And this wouldn't be just for depression, and this wouldn't be just for schizophrenia. Necessarily, you can use it in a variety of settings. Okay. Again, you can go point by point through this. I don't want to go item by item. I want you to start thinking about subnotes. I give you a case. Now, I'm not going to read the whole case, but I'm going to highlight a couple things I want you to get out of this for today. Chief complaint and reason for admission are those acronyms. This is where generally the chief complaint, as I had said before, is going to be what that person says in their own words. Like in this case, patient denies suicidal attempts and says that he has only thought about suicide as a last resort. So this person has actually vocalized and verbalized that suicide has been on the plate as a means of last resort. That's kind of a chief complaint. Like, okay, this person's suicidal. They're telling us right now that it's on the plate as an option as a last resort. That's not a good situation. HPI, now if you look in here, HPI, I've tucked in some DSM-4 criteria for depression. So when we're doing cases down the road, and we're presenting patients and doing exam questions and so on and so forth, you need to be able to start extracting the DSM-4 criteria out of the case. So just out of, we got a few minutes left. All right, Rachel's been hiding from the whole lecture. Let's go through. How many depressive criteria can you get out of the HPI? No, say them out loud. I'm sorry.
Say them out loud.
Yeah.
Sadness, low mood, lack of appetite, early morning insomnia, hopelessness. He's not taking his meds.
Staying up with him.
That's not actually a DSM-4 criteria for depression.
Oh, okay.
Now, do you think all 5 of those symptoms that you mentioned are DSM-4 criteria for depression? Anybody want to help her? Yeah, do you think they are?
Yes.
And how long do those symptoms have to be present in order for the diagnosis to be appropriate? Minimum 2 weeks. So you have to have enough symptoms. So we're going to go through this again in depression. You have to have enough symptoms over a certain amount of time for a diagnosis to be appropriate. But again, what I'm really trying to show you here is that you need to be able to extract information from the case that correspond to DSM-4 criteria. Okay? And then again, more information. This is very standard nomenclature. Past medical history, medications prior to admission, social history, family history, mental status exam, physical exam. We get to the Axis 5 diagnosis that we talked about. You may or may not at some point have the rating scale results put in here. And then when you write a SOAP note, what you're basically talking about is all of this information that you collected and you put into the categories of subjective findings, objective findings, what your assessment is, and what the plan is. So like in this case, this is like diagnosis would go under assessment, right? And the treatment plan would be the plan. I mean, that's a pretty brief plan, but we're not breaking. This is just an initial exposure to these types of cases to you guys. It's not supposed to be the end all be all. So, you're going to need to know. You're not going to need to conduct a neuropsychiatric exam, but you're going to have to be able to extract information out of the case that's given to you in order to answer questions. All right? Right? In real life, it takes practice. You forget this section, you forget that section. You thought that this was supposed to be here, it's not over there. I saw a SOAP note the other day that didn't have any categories whatsoever. How am I supposed to find the information I need if it's not organized in some format? If I'm trying to find one little finding, in the assessment, but it's in a big paragraph. Do you want to read through a whole paragraph every time? No.
Just as a clarification, when you're looking at subjective versus objective, are almost all the psych complaints mostly subjective, like I feel sad or I don't sleep well? Is that objective only measured, I guess, by like blood pressure readings or blood levels? Is that how do you determine where you draw the line between?
So yes and no. So if I told you, if I said, listen, I need you to give me a benzodiazepine because I'm fidgety, right? That's subjective. I'm reporting that I'm fidgety. But you're looking at me and I'm hopping around, and I'm dancing around, and I have clear psychomotor agitation, that you believe. You distract them onto something else, and you can still see that they're rocking, that they look uncomfortable. That's more objective,
Okay.
because that's something that you're taking in with your own, you're collecting that information directly. Good question. So again, if you were to come back, when you start athletes, for example, and you were to come, present a patient in psychiatry, it would be expected that you'd be walking through, here's the chief complaint, here's the history of present illness, here is the mental status exam, and again, it's a very standardized format. When you get to other therapeutics instructors, I know for a fact they're going to be expecting you to write a lot of soap notes along the way. You'll write a lot of soap notes along the way. I tend to look a bit more towards the literature analysis because my role is more research intensive here at UNE, so I tend to do stuff that stays continuous with what I'm doing. Other people that are more clinicians are going to want more soap notes, so you're going to get a little bit of both. So you need to know both. And if you have questions, again, I think this class technically ends at 2:15, right? A lot of times what you find is the next class starts at 2:30, so even if we run over, it's 2:15 is the target, you may run over. We have to be out of here usually generally by 2:30. The point being, if you have questions, you can feel free to ask them now instead of following me out the door in a big line. We're at meds prior to admission. Yeah.
When we're talking about the gold standards for disorders, ATO and HMD,
Madras, you're gonna see that scale the one we give to the freshman you're gonna talk about. And you're gonna see it in the article tomorrow. MADRS, and that stands for the Montgomery Asperger Depression Rating Scale. Yep. Yep. I'm sorry?
You're going to send the schedule already. So you can
Which
see
one? The stall?
online, your online.
Well, the Bureau, most instructors in therapeutics are going to take material out of the Bureau. That's the gold standard textbook that most pharmacy schools use. A lot of people take information out of the Bureau. I would definitely, I remember being in pharmacy school and I didn't always read the book, but if there was always, if you had to read something, I would read the Bureau. I don't know if that answers your question or not. It would be fair to take the question out of the Bureau, something that I didn't explicitly say, and I'm not talking about taking a footnote of the table or something. I'm talking about something obvious from the Bureau. Something that was a very clear point made in that chapter and put it in the exam. Yeah. Yeah. Right. Yeah, so half the class tomorrow and half the class on Friday, and we're going to be doing the same thing. Yeah, I'm going to put the article today. I think I have the one that I want to put up there. I haven't read it myself, so I'm still looking at which one would be randomized, good methodology. I think I found one, good journal, those things. And then I would post it, but you could spend some time at the beginning of the class reading. You've done that in the past. What is this class? An hour and 15 minutes. That's, either way, you're going to have a half an hour, say, at the beginning, or 40 minutes or whatever. First half the class to be talking to your groups, and half of you can read information you didn't read today, or whatever. But it's the beginning of the semester, you don't have that much going on. If it were me, I'd probably read it so that I could actually be informed. But if you didn't read it till tomorrow, probably not gonna set you off your life course goals.
MDD is major depressive disorder?
Yep. Anybody hear any horror stories about this class last year? Yes? Raise your hand, I can't hear it. It's anybody? It was a struggle last year, and we're going to do most of the... It was a shock for everybody last year. Because it's not just a memorization class. You have to be able to tie in things like that case where You have to be able to extract information from the DSM-4 and then say, okay, I now know what that disorder is. Okay, now that I know what disorder it is, what areas of the brain is this? And once you know what areas of the brain is, what neurotransmitter, and once you know what neurotransmitter